Go ahead, Sangram.
Yes, sir. Yeah, good evening to one and all. On behalf of API, ICP and World Medical Academy, I heartily welcome one and all for this virtual update on stroke on World Stroke Day. I welcome all delegates who have joined virtually from whichever place to learn from the esteemed faculty. I welcome our guest of honor, Dr. P.S. Shankar, Professor Emeritus, RGHS Bangalore. I welcome Dr. Maya, Patron, Dr. K. Govind Babu, Chairman API, Dr. Vishwanath, Secretary, Dr. Ravi Kirti, Central API Member, Dr. Rashekar, Immediate Past Chairman API, and Dr. Jayant Antani from our own faculty who was joined from Pune. I welcome our guest of honor, Dr. A. Muruganathan, Past President is API and Past Governor ACP India Chapter, who needs no introduction. I welcome our today's chief guest, Dr. Pratima Murthy, Director NIMHANS, one of the prestigious institute in the country, a great academician, researcher, scholar, and able administrator with many awards and publications to her credit. Lot of research activities done in collaboration with the WHO and UNESCO in field of psychiatry. I welcome our today's speaker, Dr. Vijay K. Sharma, Senior Consultant, Stroke Neurologist, working as Associate Professor, National University Hospital, Singapore. A great name in the field of stroke neurology with many awards and publications. Is a recipient of prestigious Clinician Scientist Award from National Medical Research Council, Singapore. He has published more than 250 peer-reviewed scientific papers and 24 book chapters. He is Associate Editor of BMC Neurology and also serves in editorial board of many scientific journals and serves on the steering committee of several multinational clinical trials and registries. I also welcome our today's chief moderator, our own faculty, Dr. Vikram Ude, a senior consultant, interventional neurologist, and head of neurology at Narayana Health Institute of Neuroscience, Bangalore. He is known as one of the preeminent neurologists in Bangalore, a great academician with many publications, received many awards, a dynamic neurointerventional faculty in the country. I welcome our today's panelist, Dr. Lokesh B., the head of the neurology, Aster CMA Hospital, Bangalore. He is trained in cerebrovascular sonography from National University, Singapore and USA. He is trained in peripheral nerve and muscle sonography in Italy and Netherlands, with many publications to his credit. I also welcome our other panelist, Dr. Srinivas Desai, Professor and Head Department of Neurointerventional Radiology from Jaslok Hospital, Mumbai. Dr. Desai is synonymous with advancement in radiology in India, a great academician. He works with various national and international research bodies towards advancement in the medical field, a great name in field of radiology in the country. On this occasion, I salute the COVID-19 healthcare workers for rendering their untired service to COVID-19 patients in spite of so many hurdles in the past anticipating the fourth wave. Let us not waste the time by reading their CV profile which runs in pages. Let us utilize time by hearing and exchange of knowledge with them in their respective specialty. As many delegates who have registered from many states making a national event. The advantage of virtual meeting which COVID-19 pandemic has taught a new normal life. Now we have a formal virtual inauguration.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam arogyam dhanasampada.
We are virtually honoring all our guest faculty for their tremendous contribution to their work done in their respective field in the country. Since Dr. P.S. Shankar is held up, I request Dr. A. Muruganathan sir to address the gathering.
Thank you, my dear brothers and sisters. It gives me great pleasure to be the guest of honor for this wonderful webinar, where the speaker, Dr. Vijay Sharma, who is internationally known. Stroke is always near to me. And Dr. Pratima Murthy, director, always helps us in all our academic activities. She is very knowledgeable and she gives her support whenever we approach. So we must thank Pratima Murthy for accepting to be the chief guest today. And it is relevant because always brain and the mind and the intellect all put together is a very great human being. So I think today Sangram has organized a nice program where Vijay Sharma is going to be the main speaker. My message today to all of you is, we should prevent stroke. It's not that after getting stroke, what you do. My aim in our last 10 years, I was talking about hypertension specialist, hypertension focus. When you prevent hypertension, when you control hypertension, you can prevent stroke. Vijay Sharma will agree with me. Spending time to prevent stroke is more important than getting stroke and doing all sorts of interventions. So my humble suggestion to all the physicians that they should focus and try to prevent stroke by controlling hypertension. Number two, in India, we don't have so many neurologists to do thrombolysis. If somebody gets a stroke in evaluation or gets symptoms, they should immediately do a CT scan, and then the physician should be trained to do the thrombolysis so that we can abort stroke. So that, once stroke comes, whoever is there, whichever institution is there, you cannot give satisfactory treatment. That is why for the last 5 years, we had been promoting stroke units in various hospitals where there is a CT scan, where there is a good radiologist, good physician, good intensive care setup, where the neurologist can monitor from their area. So recently we have started about 10 stroke units, and where our neurologist for each unit supervises and monitors. The crux of the matter is, before that 3.5 hours or 4.5 hours, you should thrombolyze, and you should have a good radiologist to say whether it is hemorrhagic stroke or ischemic stroke, and without any problem we can thrombolyze easily, because many people thrombolyze for a cardiac problem. The same thing can be applied to the stroke also. That's how we are promoting. So my message to all our physician friends is, stroke is not only neurologist territory, it is our territory, because we do the maximum prevention before the neurologists take over. And the number two, the knowledge about stroke, what to do, what not to do, do's and don'ts, we have already published. I've circulated to many times to the physicians about the stroke handbook. So I think with this, I request people who are interested must start the stroke unit in their respective areas and get trained. And also the nursing care also very important. There are institutions where the stroke units are, the nurses are trained. And I'm very proud to say Dr. Jairaj Pandian, who is my good friend, is going to be the World Stroke Association President-elect. So it's a great honor for India, because our own man, Jairaj Pandian, is going to be the Stroke Association President. With this, I once again congratulate Sangram for organizing this, and thank Pratima Murthy, my good friend, for participating as a chief guest. Over to you, Sangram. Thank you.
Thank you, sir. Thank you for your kind words of wisdom. Now I request Dr. Mayas. Is not joined. Dr. Govind Babu is also held up for Chairman API. Now I request our chief guest, Dr. Pratima Murthy, madam, to address the inaugural address. Over to you, madam.
Good evening to everyone. It's a pleasure to be here today at the inauguration of the World Stroke Day commemoration that the API, the ICP Karnataka, and the whole Medical Academy have put together. Thank you, Dr. Biradar, for asking me. I think it's with a lot of humility that I'm speaking today to a group of neurologists, physicians, and people who are possibly much more intimately engaged at a personal level with stroke care as compared to me. But I think being in the position that I am in, I have become increasingly aware of the lacunae that are there. And this is something that we need to discuss on this day and make sure that we address various aspects of stroke intervention and prevention in a consolidated manner. I was delighted that Dr. Muruganathan mentioned the closeness of the mind and the brain, because I think a lot of the work that we do, I mean, we make these artificial partitions ourselves, but in reality, I think there is such a close connect, even when you talk of stroke in terms of the cognitive, the emotional, the behavioral components, all of which can be impacted in terms of the occurrence of stroke. We all know that stroke is something that is of a global concern, and it causes a huge amount of morbidity and mortality. And globally, 1 in 4 people are said to have a stroke in their lifetime. And in fact, this is something that we were discussing this afternoon at a program in NIMHANS, where Dr. Vikram Huded was also there, as well as Dr. Nagaraja, our former director, who has done a lot of work in stroke, particularly in CVT, and has set up also the stroke unit at NIMHANS. And one of the things that we spoke about, and I'm again glad that Dr. Muruganathan alluded to that, is to increase awareness of the risk factors of stroke, and to recognize the symptoms of potential stroke. In fact, this afternoon, we had 2 family members who told us, when there was a lady who said her husband, suddenly fell down and had these grimacing moments, and she thought he was doing it in jest, till she realized that, he lost consciousness. Similarly, another one, I mean, it is actually quite astonishing that even in this day and age, people are not able to recognize symptoms. They attribute even, to certain mystico-religious influences. So I think we have a long way to go in terms of making people aware, especially of the early symptoms of stroke, and to know where to immediately take the person to, so that there is no delay, which is really this year's theme about the precious time that, is to be kept in mind, and the early identification and prompt, going to treatment. And we all know that the time factor is very crucial, and the importance of stroke-ready institutions is also very critical, particularly when there has been a stroke. And we're, of course, a stroke-ready institution. We have a 24-bedded dedicated facility, both for acute as well as chronic stroke care and management. And I think our biggest USP is the fact that we have a fantastic multidisciplinary team, not just of neurologists, interventional radiologists, neurosurgeons, departments of physiotherapy, nursing, of course, occupational therapy, neurochemistry, neuropsychology, speech therapy and audiology, and the psychiatry, psychiatric social work, epidemiology, health education, dietary departments, all of which are very closely connected with the care, both acute care, the rehabilitation, and the recovery from stroke. And that, I think, makes us in a very unique position. But we also have interventions like the thrombolysis that you were talking about, the mechanical thrombectomies and so on. And therefore, we are able to provide such timely access and quality stroke management. But our problem is numbers, the sheer numbers of people who need to come to us. And therefore, we're thinking very, very seriously about evolving a hub and spoke model where we can actually train, just as was being mentioned, train doctors in medical colleges, in district hospitals, and develop a good, interactive system so that only the persons can receive timely treatment, particularly for stroke. And I think the other thing that we have been doing is called the Karnataka Brain Health Initiative, where one of the things is really to help people in particularly in primary and secondary care facilities, both to educate people, to address all the risk factors for stroke, and make sure that people's diet, control of hypertension, other metabolic factors, substance use, etc., are dealt with. And of course, that there is prompt recognition, referral if necessary, or basic management that occurs. We were talking about the lack of neurologists, particularly interventional neurologists in the country. So I think if we are going to really address a problem like stroke, it has to be multidimensional, multidisciplinary, and we need to constantly talk about it. I mentioned in the afternoon that our discussion about stroke management and prevention should not be confined to World Stroke Day. I think we need to look at larger factors, both in terms of the risk factors and how to address them, as well as making sure that we are properly networked so people don't waste time coming to facilities and get the treatment that they deserve. I think Dr. Hudaid also very nicely mentioned how you can actually turn around and reduce the mortality. I think we're constantly doing that. I think addressing the risk factors itself is reducing for how hopefully the severity of strokes and their prevalence. But I think we have a long way to go in terms of managing it in a much more meaningful manner. I'm so glad that so many people have come here today, and I'm sure that the talk by Dr. Vijay Sharma and the panel discussion that will follow thereafter will be very illuminating. Thank you very much.
Thank you, madam, for sparing your valuable time and your advice on this stroke day. Thank you once again. Dr. Govind Babu? Yeah, just now joined. Yeah. Kindly go ahead.
Thank you, Dr. Sangram. It's wonderful that you have put in this program. And I don't think I'll waste much time in taking about this. So I'm sure you have a host of speakers lined up there. So over to you, Dr. Sangram. Thank you.
Yeah, thank you. Thank you for your Now we move on to scientific session. I request Dr. Vikram Hudaid to take over the podium. Dr. Vikram, sir.
Hello.
Yeah. Since Dr. Vijay Sharma and all the other faculty already have been introduced,
Okay,
so I request Dr. Vijay Sharma to speak on the topic. Over to you, Dr. Vikram Hudaid, sir.
Hello, sir. Good evening. Good evening, everyone.
Yeah.
I request Professor Vijay Sharma, sir, to give his talk on stroke and the role of interventions.
Thank you very much, Vikram. Let me just share my slides. You can see my slides, huh? So, thank you again for organizing this WSO day. Before I start, I just tell you what was happening in the morning when I heard about primary prevention. So we had a Singapore Harvard conference in the morning, and I was giving a talk and the discussion started and somebody talked about primary prevention. The question of primary prevention is that it starts in today's world as soon as we are born. So if you want to really go for primary prevention, start it at birth. There's no way that you can think of starting primary prevention at the age of 30 or at the age of 40 or 45 or 60. There's no way. It's a continuous thing right from the birth. This is today. It's already happening, and it will happen probably, I feel, in 5 years' time, that people will start primary prevention for stroke when they are marrying. The boy and girl, they will go to a pathologist or physician or a geneticist to do their gene analysis and find out what is their risk of stroke. And if the stroke risk appears high on the gene analysis, probably they are not going to marry. I feel this is the future where we are heading towards. So coming to the talk, I was asked to talk on stroke and role of interventions. And I thought that because this is mostly a general physician's audience, some general neurologists, I'm going to keep it a very simple talk. There will not be any complicated things in the talk, so that everybody can just have an overview. What are we doing at present and why are we doing the things? This is the burden of stroke. So we talk about Singapore. I don't know how much the numbers will become for India, but in Singapore, this is what is happening. 26 new strokes are occurring each day. So that becomes like more than one stroke every hour. It's quite a bad disease. Now, if you want to have an overview what happens for stroke, so this particular flow chart is applicable to most parts of the world, including India. India, the situation may be a little bit worse than this because of the strokes occurring even in younger ages. So if you take that 1 million inhabitants, you've got 10 lakhs in India. So if you take 10 lakhs, so what we see every year is 1,800 first strokes. In addition to that, we see about 600 recurrent strokes or TIAs, and then leading to stroke. So total becomes 2,400. So on a 10 lakh population, we see 2,400 strokes every year. Out of these, nearly 50% are going to be independent. Independent means they can return back to independence, means that they can do their things, but it does not mean that they're returning to work. Return to work occurs hardly in about 30-35% patients. So return to work is much worse as compared to becoming independent. About 25 to 30% people that die, depending on the country or the center. The biggest problem is for the 25% patients. So from 10 lakh patients, 2,400 strokes, that means 600 patients will survive the stroke, but they will be dependent. And the meaning of dependence is for one activity of their life, feeding, walking, bathing, dressing, and shifting. Now, all these things, that means they require help of another person. So what is happening? Once they survive, they have a long life, almost like full expectancy of life. So we are returning back to society for every 10 lakh individuals, 600 patients and 600 caregivers. It's a huge burden. That means 1,200 people are either stroke survivors, they are just living, or they are taking care of the stroke patients. These people are not productive members of society at all. So that is a huge economical, financial, social burden. How to look after such a population. And this is a cumulative number. And this is happening on a daily basis. So how to reduce this burden? That is the role of primary prevention. All the interventions which we do, they are shifting some patients from this group of being dependent into becoming independent. This is what our interventions have done. And there is a remarkable change over the last 15-20 years that we have moved a lot of patients from being dependent to independent. And Vikram is one of those who is contributing probably maximum out of all stroke physicians being interventionalists, because he deals with those stroke patients who are definitely going to be disabled if they are not treated in a center with facilities and in time. I will be talking mostly about ischemic stroke, but that is the burden of the society. 88 to 90% patients, depending on the place where you are ischemic strokes. Hemorrhagic strokes, subarachnoid hemorrhage, they are a little bit of different kind of strokes. They have a different kind of outcomes, different in treatments. So I'm not going to touch on them. I'm going to talk about the major burden on us, which is ischemic stroke. And I will start with hyperacute treatment. And this is the most important component of interventions which we have at present. So I always say that stroke physicians, they are the luckiest people in the physicians community, because they need to read only about one medicine. They don't need to read about two medicines, because that's the only medicine which is approved in the world. Those people who practice in India, they are a little bit less fortunate, because now they have to read about two medicines. The Altiplase, which is TPA, and the other kind of TPA, which is Tenecteplase, because Tenecteplase is approved in India. But we are very lucky, we learn only about one medicine. So there is no excuse that you do not know the actions of the medicine, that you cannot say that I don't know the side effects of the medicine. I cannot say that I don't know the pharmacokinetics and pharmacodynamics about it, because that's the only medicine which I know. And I don't know anything about other medicines. Other medicines are for other purposes like blood pressure control, diabetes. And I can safely say that is not my domain. I can do the simple things, but not more than that. So my medicine or my weapon is only TPA. So I always say that's why stroke is the easiest disease to treat, easiest disease to handle, because you are never going to do a mistake. Either you give it or you don't give it. And the other beauty is, if you are giving it, you need to give it only during first 4.5 hours. If this is 271 minutes, you can say very safely, I don't want to give even this medicine today. We are trying to increase this duration when we can administer the medicine. This is our enemy. Whenever you are fighting a war, you need to know about your enemy, and only then you can fight it. So that is the structure of the blood clot. This is what troubles stroke patients. So what you see is that these are all fibrin threads. They are being held together by these activated, angry looking platelets. So when they are held together like this become like a web. And this web will trap these RBCs, which were supposed to provide oxygen to the brain. So they are trapped. So these RBCs do not reach the parts of the brain. And that part of the brain dies because it is ischemic now. It does not get oxygen supply. So it starts dying. What we need to do is we need to break these fibrin threads. So that's why our medicine TPA or tenecteplase both are called as fibrinolytic agents, although we call it thrombolysis. But in true words, we are doing fibrinolysis. So we are just breaking these threads. And once you break them, RBCs are set free and they can go into the periphery of the brain and supply and keep the brain alive. One concept which everybody needs to know is core and penumbra. Core means that is the part of the brain which is affected most. And that's the center of the damage which is occurring. It is just about 10-15% of the blood flow is there, or even less than that. So this part, nothing can be done. This is the part of the brain which starts dying as soon as this is 3 minutes. So within 3 minutes, this starts dying. So this part is nothing can be done. So this is gone. What we are more interested is penumbra. Penumbra is surrounding area to the core. That area is having a cerebral blood flow which is less than 40% of what it requires. So that amount of blood, it keeps this part alive, but it does not function. So it's not functioning, only it is surviving. Now, if we are able to dissolve the blood clot or remove the blood clot, that penumbra will be salvaged. So all treatment is salvaging the penumbra and achieving the recovery in patient. So if we are late or our techniques are not able to salvage the penumbra, this penumbra will ultimately get converted into core and result in a permanent damage and a permanent neurological deficit. So we are doing salvaging the penumbra by all treatments which are doing at present. And this is exactly what happens. There are two patients, similar patients. This is a CT scan showing a hyperdense middle cerebral artery on the right side, showing that there's a clot. And this is another patient with a CT angiogram, which shows that there's an occlusion of the right MCA. Both have right MCA. On this patient, the upper one, we could dissolve the blood clot and we end up with a very small stroke, which is subcortical, and the patient improves very nicely. In the patient lower down, somehow we could not achieve recanalization. So the core was already there, and even the penumbra got incorporated into the core, and we end up with a major stroke, and the patient ends up being paralyzed on the left side of the body, which is a permanent deficit for him. So he is disabled for his life. This is what I told you, that 270 minutes. That is the current concept, that do not treat the patient once it is 271 minutes, unless you have a compelling scientific evidence that this person may benefit with thrombolysis. If you have modern imaging, yes, we do thrombolyze some patients. If we do have sophisticated modern imaging, which tells us that we are still in that window where there is sufficient amount of penumbra and TPA may be used. The trials are being conducted somehow to extend this window of opportunity. You can see very clearly, as we are losing time, the chances of recovery, they are rapidly going downwards. And the moment you hit 270 minutes, you can see one of the confidence intervals, it starts touching the line of unity. Line of unity means below this, the treatment, not only it is not of much use, it starts becoming harmful. So we don't thrombolyze at present anybody who is more than 270 minutes from the time of onset. So here comes the importance of family members, relatives, bystanders, people on the road, that if somebody has a stroke, bring him to the hospital. This is race against time. This is called time is brain. If you are able to save 1 minute for the patient, you are saving about 20 lakh brain cells. This is the amount of save in the brain if you can save 1 minute. It's not that somebody got a stroke, I have 4.5 hours to treat the patient. No. If the patient can reach me in 5 minutes time, he will be the best candidate to receive the treatment as compared to the patient who reaches me 230 or 240 minutes. So earlier the treatment, best is the benefit, best is the chance for complete recovery. And these charts just show how it happens. In patients who are treated within 90 minutes, there's a huge change in the outcomes of complete independence. That means These are the people who do not have any demonstrable neurological deficit. You can see how much is the number which we can shift towards this side. But as we are going away from that 90 minutes window, from 91 to 180, 181 to 270, you see this becomes horizontal. We don't find much evidence. And you can see it here as we are going here. In all three of them, even the mortality starts going higher than the placebo. All three of them. So the treatment, not only it's no longer that much effective, it starts becoming potentially harmful to the patient. Very simple indications. You need to have a patient. You need to have a very clear time of onset. You need to have a CT scan which does not show a bleed, bleed on the brain. And that's all. All other inclusion criteria, you don't need to look at it. You need to just calculate how much is the dose which I need to give. The total dose is 0.9 milligram per kilogram body weight. We go not more than 90 milligrams. 10% is given as bolus, and rest we infuse over 60 minutes. Don't look at contraindications, because contraindications, when I was trained, it was a huge list. And over years, we have removed most of the absolute contraindications. Many of the contraindications have moved into relative contraindications, and relative contraindications have moved towards the discretion of the treating neurologist, whether to really respect it or not respect it. I always say there are hardly any contraindications in my patients, unless there's a compelling reason that there is a very high risk of bleeding. That's the only time when I don't give TPA. Otherwise, almost everybody receives TPA. It has to be a really very strong exclusion criteria not to treat. And this is exactly what happens. Like in this patient, she is a young patient. 57 is not an old age. This is the most productive age for a person when it comes to working. She did not have any past medical history and suddenly becomes unresponsive early in the morning when she was getting ready to come to the hospital. And she was brought by the family members. We did a very rapid CT scan, and what we found was that her NIH stroke signal is 30. 30, nobody calculates. It is a guess. Everything is paralyzed. You can see it. The right upper limb, lower limb, they don't have any power. Left side, there is some flexion to the pain. It's a minimal power. It's a useless power, actually, even if you have 2 and 1. The only movement which she could do was little bit of movements of the eye. Otherwise, she was ophthalmoplegic. Even eyes were not moving. Just little bit of movement, flicker was there. She was mute. She could not talk anything. Sounds were not coming. This is the CT angiogram for the patient. You can see beautiful intracranial ICAs, the internal carotid arteries, MCAs are clean, ACAs are clean. The problem lies here. Only you see the distal basilar artery. There is no proximal basilar artery. There is no vertebral artery which is visible. So it's a complete occlusion of the proximal 2/3 of the basilar artery and the proximal vertebral arteries. I did the transcranial Doppler, absolutely no flow in posterior circulation at all. What you're seeing here on the flow, these are just arterial pulsations which you are seeing. Absolutely no blood flow. Transcranial Doppler is very sensitive for picking even the slow flows, which we did not see. I gave her TPA and I started monitoring her. And this is the proof that how the artery opens up, how the clot dissolves, how the blood flow starts improving if you are able to dissolve the blood clot with this TPA. You can see from no flow, we start seeing trickle of flow in the brain, in the basilar artery. And slowly, this flow starts improving. And not only it improves, normal bleed flow. And when I was doing this monitoring, every step, this took 22 minutes only for recanalization. And during these 22 minutes, you were seeing how one by one, she started moving the right leg, she started moving the left leg, she started moving the right hand, left hand, she started talking. And she even removed by her own hand the probe because probe was hurting her head. She removed it. She said, "What are you doing for me?" She became totally conscious. And you can see it. Every single artery, whether you're talking about basilar artery, you're talking about ICA, you're talking about the vertebral arteries, everything opened up and everything became normal. And that was a magical effect. Just out of curiosity, I took this patient for repeat CT angiogram as soon as they completed TPA. And you can see there's a complete recanalization. This is what the artery should have been. And this is what we saw in the beginning. There's a complete recanalization of basilar artery. There is a complete recanalization of the left vertebral artery. The right vertebral artery is hypoplastic, so it will remain like this. Whatever flow was there, it was achieved. And we could discharge this patient on day 3, walked on our own. We want this kind of recovery in every single patient. Unfortunately, we are not that fortunate to see these patients, every patient having the same kind of outcome. We do see in a large number of patients. I can tell you, if a patient comes to my center, nearly 50% of them, they achieve a very significant recovery, but it's only 50%. And this is what we are worried when we give TPA. That are we harming the patient? This is a symptomatic hemorrhage. This is a bleed caused in the stroke area in one of the patients. This is an unwanted thing. The quoted risk in scientific literature is 6.4%, but it's not 6.4% at all. In every good experience center, this risk is just about 1% to 1.5% or maximum 2%. It's never more than 2%. If it is going more than 2% at anybody's center, look at your blood pressure protocol. If you are very meticulously controlling blood pressure within the standard guideline limits, there is no way that you can have a bleeding complication in more than 2% of your stroke patients. These are the problems with TPA. We are not happy with the drug. The reason being, we can give it only for 4.5 hours. That's a big limitation. We need to give it over 1 hour. That means I need to stay with my patient 1 hour, continuously monitor him. The recanalization rates are dismal. They're not very good. Like in ICA, the recanalization rates just about probably 6%, 7%, 10%. For basilar artery, it may go up to around 20%. For distal MCAs, it may go as high as 40%, but it's not more than that. Then we don't see the Lazarus effect. The Lazarus is from Bible. It's a mythological character, which is a magical outcome. That I showed you a case which was a magical outcome. But magical outcomes, they occur only probably, I say it once in a year or maybe twice in a year, that kind of magic, but not more than that. So it's not a magical effect with TPA. We still have to quote this 6.4, but I told you it's not 6.4%. This is just, I quote 1 to 2% risk. It's not more than that. And only few patients recover more than the placebo. That's another problem. Another problem is I have to wait for 3 months to certify that this patient has recovered, or what is the extent of recovery. I cannot tell you on day 2, day 3, day 4. That's a big problem with TPA. We need a better agent. India has found the solution. You have tenecteplase, which is definitely a better fibrinolytic agent scientifically. It is having a very high specificity to fibrin. So that means it might be much better than what TPA does. 2, it's given as a bolus. So you don't have to stay with the patient for long periods. 3, in clinical trials, it has shown that the recanalization rates, the dissolution of thrombus, it's much higher as compared to TPA, the currently used alteplase. Now, this has changed our stroke patient's life. So endovascular treatment, Vikram probably is one of the proponents of this in India, and I know he remains very busy. And these are the people who are definitely giving a second life to most of the patients, because they are seeing the patients who are the real severe strokes. TPA can be given even to minor strokes, but they are the one who are seeing severe strokes. And this is what they do. They do this magic. Like in this patient, there's a blood clot at just the terminal ICA. These patients were believed initially to have more than 50% mortality within 3 months, or even during the hospital stay. More than 50% mortality. Every second patient was dying when they were having this kind of thing. So you give this patient to Vikram, and he's going to take the clot out, and he's going to keep this patient not only alive, but alive with a significant amount of recovery. You can see complete recanalization just because he removed the clot. This clot could not have been dissolved with TPA alone. They started using this historical device called Mercy Retriever. It will trigger like this, go into the clot, very easy to save, very difficult to deploy. It did not survive because it had huge complication rates, very difficult to deploy. Success rates were not very good. So nobody used it. It was used just in early 2005 to 2003, 2004, 2005. And beyond that, nobody used it. They used different kind of stent retrievers. These are not detachable stents. They open it up in the clot. It opens up, absorbs the whole clot gets organized in this trap. And then they take this clot and the stent out, and the entire clot comes out. This is a magic. This is definitely a magic. And the magic is like this. This is a meta-analysis, pooled analysis actually of all the patients who were recruited in first 5 successful clinical trials, which were ESCAPE, Extend IA, Mr. Clean, Revascate, and Switch Prime. And it was shown very clearly that the number need to treat is just about 2, 2.5, 2.5. That means every second patient, you are going to have excellent outcome. This is the wonderful intervention which has been developed. It has changed the whole practice. And you can see it, modified Rankin scale of 0 to 1 is what we want. Those patients who are not receiving endovascular treatment or mechanical thrombectomy, only 12 or 13% patients were showing some kind of independence. We have more than doubled this rate. But if you're talking about the modified Rankin scale of 0 to 2, 0 to 2 means these people are all independent. They may be having some symptoms and signs, but these signs are not disabling signs. They can take care of themselves. They can return back to work. They can walk on their own. They are not using any help. They are just having some minimal deficits. You can see it, 45% means every second patient we are giving them an independence. So this is what we want. We are not happy with this number. We want to increase this number to probably 100%. We don't want even 99%. 99% means even one patient we are leaving behind who was disabled. This is what we want. But initial trials which I showed you, they were using it only up to 6 hours. So 6 hours was again a limitation. If the patient is coming at 6 hours, 5 minutes, he was not eligible. Then the clinical trials were done, whether we can do it up to 24 hours, 16 to 24 hours. There were 2 clinical trials, Diffuse 3 and Dawn, and both of them showed very clearly, yes, you can select the patient based on modern imaging techniques, select your patient who will benefit, and then you can go ahead with thrombectomy up to 24 hours, and you can still achieve wonderful results, still send additional patients to the community with functional independence. You can see it here. It's a huge difference. It's not a small difference. You can see 8% from complete independence, no symptoms, no sign, to 10. But if you combine the two, 12 versus 26, it's not a small number. It's doubling. It's doubling the chances of survival. And not only that, you can see it, it was reducing even the mortality, reducing by half. So that's a paradigm shift that we can treat these patients. Sometimes we end up into problems, especially with younger patients. The stroke occurs. A stroke is an injury to the brain. And we know, all physicians know, that anywhere there is an insult or injury, the reaction of the body is swelling. Same swelling occurs in brain. Our brain is in a bony cage. Once the brain starts swelling up, there's no way that it has a place to swell outside. So it starts killing its own neighborhoods. The small stroke starts becoming bigger. Not only bigger, it starts shifting the brain to other side or downwards, risking the life. So we can do the decompression, means we remove a small part of bone just overlying the stroke, like in this patient. We allow the brain to swell outside. We know the swelling is a temporary phase. We don't have very good agents at present, medical agents, to reduce swelling. They're not effective at all. They are not evidence-based also. But this is evidence-based. We can cut a small part of bone, let the brain expand outside, and we know within 3 to 5 days the swelling will subside. Once the swelling subsides, patient improves. And then you can bring the patient back later on, either put his own skull plate here, but nowadays most surgeons don't want to put the plate back. They don't want to keep the skull. They just do a titanium cranioplasty, give shape to the skull, and the problem is over. Again, the thing is, earlier you treat. So everything in stroke is, if you really want to treat, do it early. Don't wait. So earlier means within 48 hours. You need to operate this patient. That means there's an anticipation. You are saying, this is the patient who is going to swell up. I don't want to wait at all. I'm going to do the decompression. Not only I'm going to save the life of the patient, you can see the reduction in the mortality. With surgery, the 71% mortality is reduced to 22%. This is again the pooled analysis of 3 clinical trials. The names were beautiful: Hamlet, Destiny, and Decimal. These were the 3 trials which were done. You can see how much death we are preventing. And not only that, we are preventing, not in addition to preventing, we are sending patients out who are having functional capabilities. So that is again a life changer. I'm not going to talk much about stroke prevention. because that's a totally separate topic. And I told you very clear, stroke prevention primary starts from birth. Secondary, yeah, after the damage has occurred, you don't want to have another stroke. And I'm going to talk only about atrial fibrillation. But that is the biggest shift which has happened. Number one, it carries a very high risk of stroke, 6 to 10 times higher risk of stroke if you have atrial fibrillation. Aspirin does not work. If you see the NICE guidelines in UK, it just says if you cannot offer anticoagulation to these patients, do not even offer aspirin. You're going to harm the patient rather than providing him any benefit. That's a very strong recommendation from a guideline. We were struggling for last 50 years with warfarin. All problems with achieving INR, keeping INR in tight control, diet control, drugs control, drug-drug interactions, we were struggling with them. Today, we have all these newer direct oral anticoagulants, whether you are talking about dabigatran, apixaban, rivaroxaban, or edoxaban, which is also available in most parts of the world. So we have got 4 agents today. These agents are beautiful agents. Number one, short-acting drugs. You don't need to monitor INR for them. They reduce even the hemorrhagic complications, which are a big problem with warfarin. So these are the wonderful agents for stroke prevention. Just identify that person is having atrial fibrillation, whether it's an established atrial fibrillation, permanent, persistent, or it's a paroxysmal atrial fibrillation. So we make all attempts to not to miss paroxysmal AF. These patients need some prolonged monitorings. Whatever is the capability at your center, go ahead with it. We are struggling now in this era with young strokes. Somehow the age of stroke is shifting downwards. More and more younger people are getting strokes. Probably lifestyle modifications are needed. These are the ones who are having the risk factors are coming early in age, or they have some genetic predisposition, or they may be having something else. Like this is a 46-year-old teacher. He had 2 episodes. One episode in the class, he could not write anything on the board. And on second occasion, he could not talk in the class. He became mute. He wanted to talk, but suddenly no sounds were coming out. So this is how he was brought. His CT scan, CT, angio, all were normal. We did ultrasound carotids normal. We did TCD. There was absolutely no stenosis, which was not seen even on CT angiogram. We did his thrombophilia screen, did not show anything abnormal. Vasculotic screen, all normal. Now, these are the patients. Once we do their MRI, you look at it, the strokes are everywhere in the brain. So they are on both sides, multiple arterial territories. We know it that something is wrong. There's a blood clot which is coming from the heart, from somewhere, which is causing it. And one of the commonest causes is atrial fibrillation, but this is a relatively young patient. Chances of finding atrial fibrillation in this patient is not that high. If he was 70, yes, I know that there's a very high chance I will pick up paroxysmal AF. But in a younger age, I look for other causes. So there was no, we did repeated monitoring for AF. We could not detect any runs of AF. But this patient was having a right to left shunt. That is a congenital patent foramen ovale, which he is having. This is a very simple test which we do or TTCD sitting upright. This patient is sitting here. This is having a transcranial Doppler probe, just monitoring the blood flow. And this is how this test is done. This is the blood flow in the brain, which we are monitoring. This is the apical 4-chamber view of 2D echo. This is the right atrium. Just remember, this is the right atrium. And on echo, this atrium is black in color. Black means there's a blood inside. So right atrium is black, left atrium black, left ventricle black, right ventricle also black. This is the arm of the patient. We have a cannula here connected with a trivay. There are 2 syringes. One syringe contains 9 ml of saline. It contains 1 ml of air. It contains 2-3 drops of patient's own blood. And we shake. We are just shaking this solution about 15 to 20 times just to break this 1 ml air into micro bubbles, and then we inject into a vein. I'll show you how this test is done. We are monitoring this and we are monitoring this. Just remember, after we inject, keep looking at this. Once it becomes white in color, that means the bubbles have reached to the right atrium. Let me just play it one more time. Somehow it's, yeah. So you see, this is mixing solution. Keep looking here after we inject. You see, this becomes white in color. All the bubbles which we created, they have reached the heart. Then he is doing a Valsalva, going air into a spirometer. Because of this, the bubbles start reaching on the left atrium, left ventricle. You can see the tiny white bubbles, and you can see these microemboli are appearing in the brain. So we injected the air bubbles into a vein, and that has reached the heart. If it reaches in a normal person, these bubbles will go towards the lung from the right ventricle, and right ventricle and our pulmonary capillaries, they are going to filter them out. Nothing will reach in the arterial side. Once they've reached the arterial side, that means there is a connection somewhere between the right and the left side of the heart, or a pulmonary AV fistula, which is conducting these through this shunt, and they reach anywhere else. We found that this patient was having a PFO which was big. We closed it with Emplazer device. We continued aspirin only for 6 months, and then we stopped. I have been following up this patient for 6 years. Absolutely no medicines are being given to this patient. We don't worry about the bleeding risk caused by aspirin at all, because there's no aspirin after 6 months. The PFO was closed. So we can cure the cause of the stroke, provided you identify it properly. This is a paper which we published about when to close, when not to close. If somebody is interested, it is written in a very simple way, like a traffic light system, that if it shows a red color, that means this PFO should not be closed. If it's a green color, yes, there's a strong recommendation, go and close it. If it shows an orange color, think again, evaluate the patient, and then find out whether really you want to close it or you want to avoid closing this patient. The last thing which I'm going to show is the atherosclerosis intracranially. That is our own Asian disease. You can just compare like this. If you have a pure Caucasian population of stroke, you take 100 patients of stroke and you look for atherosclerosis in intracranial arteries, the incidence is just about 8 or 9%. Now you give me an Asian population. Now I don't know what will happen to a pure Indian population, but I can tell you in a population in Singapore where I have 60–70% patients who are Chinese, the rest are mostly Indians or Malays. We see about 50% of patients having stenosis in one of the intracranial arteries. It's a genetic condition. It's some genetic abnormality which plays with our diet or lifestyle, which causes intracranial stenosis. Because it's an Asian disease, nobody will do a proper research for us sitting in Europe or sitting in US. We have to find out solutions for this disease. The most important thing in this condition is it causes stroke, which ranges from a 15% risk on a yearly basis to all the way about 45% per year. That may be the risk if the stenosis is severe. So this is a bad disease. So this is one, again, a youngish patient, 56-year-old patient, recurrent episodes of right-sided weakness and speaking difficulty. So it's a cortical TIA which the patient doubling, and you can see there's a severe stenosis of the left middle cerebral artery. The question which comes to the clinician is, are we dealing with embolization? Are we dealing with hyperperfusion? Are we dealing with a combination of two? Or are we going to have bleeding in this patient later on? Very simple test, look for emboli, identify emboli. So this is how emboli looks like, a tuk kind of sound, spontaneous. That is that if you see this emboli, you know you need to give this patient strong antithrombotic therapy. You need to give this patient strong statins. These emboli will disappear and patient will improve. The problem comes if it does not improve, if the emboli are not there. Then we have treatment options. Vikram is already doing some stenting for these patients. At present, stenting is an evolution. 5 years later, yes, stenting probably will become the first treatment of choice. Today, no. We do some surgical corrections for these patients doing a bypass surgery or other things. Stenting trials, which is quoted, it's an old trial now, already 11-year-old. It showed that medical treatment is much, much better as compared to the stenting, because stenting was associated with more than 10% risk of peri-procedural events. We don't see that much of peri-procedural events nowadays. We are improving on that. For this particular patient, we did this STA-MCA bypass surgery, the superficial temporal artery to middle cerebral artery surgery. You can see the bypass is working very nicely. This patient, not only it's improved in cognition, but also in cerebral hemodynamics. Also, that was a big secondary prevention in terms of stroke preventing. This patient never had a stroke. I have been seeing this patient almost for 10 years now. There has been no stroke at all. So it works. But again, the problem, it's a surgery. Carries surgical complications. So not readily acceptable. This is a SPECT for this patient. You can see a huge improvement which came to surgery. Almost both hemispheres, they look almost similar now in terms of metabolic perfusion. So we can do it, but you need to be very selective because it's a surgery. You don't want to take much risk. You still want to treat them medically and find out solutions. We are trying to find out other solutions. This is the last thing which I'm going to show you. It's still in research phase called external enhanced counter pulsations. It is same like intra-aortic balloon pulsations, except it's non-invasive. We do it from outside. This is how we do. This patient is lying on this dedicated bed. These are the blood pressure kind of cuffs, one on the leg, one on lower thigh, one on upper thigh, on each leg. It is connected with the ECG. It's synchronized. So this is how this test is done. You can see this patient is just resting on the bed. He's very comfortable looking patient actually. He's just jumping up and down because these bulbs are inflating during diastole. This is what happens to the blood flow. This is the ECG of the patient. This is finger plethysmography. That means blood flow in the finger. You can see it when we do this test. When we do it, it is the blood. Keep looking at when we do the one thing on the next drop. You see there will be testing here. You see we are increasing the blood flow in diastole. So suddenly it starts appearing the patient is having a double peak everywhere. What we are doing with this test is we are increasing, we are doubling the blood flow in every cardiac system. And when we double the blood flow, this is what happens. This was before at rest. You can see this was the blood flow in the brain. This is the blood flow when we do the inflation. And this is, you can see there are two peaks. The heart rate does not change. Heart rate has remained same. You can see this heart rate 84 here, heart rate 88. Heart rates have not changed. It's just that during diastole, we have increased the blood flow. That means with every cardiac cycle, we are pumping double amount of blood flow into the brain. Brain has to keep it somewhere. Brain opens up new collaterals, and these collaterals mature over 35 sessions, and then it will keep working. This is what we did for this particular patient. Bilateral severe MCA stenosis, recurrent strokes. See, this is a severe stenosis of the left MCA. There is no blood flow noted in the right MCA. We put this patient on this counter pulsations, and you can see how much. So this was a perfusion deficit on this patient's right MCA. You can see it after treatment. It has totally resolved. It has come back to normal. Now the two hemispheres, they look exactly same, even before at rest as well as after Dymox challenge. There is absolutely, this Dymox challenge is same like what cardiologists do in MIBI. We are challenging the brain. So total reversal of the cerebral perfusion. We increased when we did the MRI ASL, we saw it that there was 21% increase in cerebral blood flow in the right MCA territory. You see there was a reduction in right MCA blood flow here. It has totally reversed. So we have a technique which works. It's a temporizing technique. It's not a permanent technique. We still need to find out permanent solutions. Stenting will be definitely an option in next few years. Already trials are being conducted. I'll stop here. It's a leading cause of mortality and really a leading cause which we don't want, the long-term disability. We need to have more interventions which are early, can be done late also, and more effective to achieve good functional recovery. We are still finding out better treatment options for secondary stroke prevention, but I totally agree. Rather than treating after a stroke has occurred, treat the patient before the stroke occurs. That is the best way for treating. We need to all change our lifestyle so that strokes don't come to us at all. That will be the best day. I will be the happiest person to lose my job when there are no strokes. Because if there are no strokes, university is going to terminate me. I will be totally redundant. I will be the happiest person if that situation comes in my lifetime. Thank you very much.
Thank you. Thank you, sir. Thank you, sir. Thank you for the wonderful presentation. It was, as usual, your talks are excellent. So I think we'll start the panel discussion. I'll invite Professor Srinivas sir and Lokesh for the discussion, and I request Vijay Sharma sir also to be there. So we are doing primary prevention and secondary prevention since long time, and that is important for India country as a whole. Even the government NCD program is focusing on that. But IV thrombolysis is there since more than 20 years, correct? And in India, hardly 1 to 2% of patients are getting IV thrombolysis. So, Dr. Lokesh, how to improve the IV thrombolysis number?
Definitely, if you look back how we started maybe a few years back to now, definitely there's been a significant change, what is interesting is like, I mean, I do a lot of camps, I just go to different district places. The good news is even in places like in district places where there was hardly this program is there, now it is definitely has picked up, and it is really good. The best part is patient education has been the forefront, and like as we have been doing in Bangalore, like how you guys are doing about Karnataka Stroke Foundation or Bangalore Stroke Foundation, we're doing a lot of such activities. Patient awareness is the key, and more such activities, and these programs should go into the district places and from district places to the towns. Otherwise, all the programs have been around the cities. I mean, it's good that in Gulbarga, we are having this program, thanks to Dr. Biradhar sir for conducting this. Unless until it goes into the districts and to the towns, I think we will see the next scale of improvement. That's what I feel.
No. Now, for example, MI, all physicians, they don't hesitate to thrombolyze.
Yes.
Because most of the physicians know that there is a drug available and thrombolysis can be done, but still there is a hesitation. So how to overcome it, sir?
It is only through CME programs, and as the number of neurologists increases, and we need to go to the district places and district places to the towns. That's the only way that this can increase. And it's happening. In the last 5 years, I can say I have seen myself compared to 5 years back, in the last 5 years, because a number of graduates who are passing out have doubled and tripled. It is definitely a changes there. Like in district places, to say to Professor Vijay Sharma, like when I came for a fellowship to you to now, in district places, we hardly had 1 or 2 neurologists. Now there are 10 to 15 are there. Now, these numbers are increasing, and the stroke centers, even in smaller, decent nursing homes, and number of availability of MRI scanners have increased. The only thing is awareness, and we need to empower physicians. There are physicians who are willing to do it, because CT scan is available, at least in towns also decently, at least in Karnataka, I can say CT scans are available, and we need to empower, and it's happening. But only way is like we need to move out from the cities to go to the district places and towns. Empowering the physicians is very good this thing. And now we have this Tenectes. I think it is easier to thrombolyze compared to recombinant tissue plasminogen Actylis, because it is ease of administrating is good. And other thing is WhatsApp also has changed.
Cost-wise also, Tenectes is lesser than Actylis. Earlier, many patients were not affording Tenectes.
Yes.
Actylis, that was one of the reason. I think now, because of the cost, Tenectes is less, and bolus one shot. I think the number should improve gradually.
Definitely.
So Vikram, this problem is not India. This problem has been everywhere. Availability of physicians. I can tell you that there is a $10 million grant which is in US to develop about 5,000 nurses. They are called as nurse clinicians, and they are being trained how to administer thrombolysis in periphery. But they do it under supervision, which is just a telephonic supervision. Now everywhere, everybody is having a WhatsApp. You can virtually do every single thing, doing NIHSS, looking at patient's weight, examining the patient through WhatsApp, and you can just guide this nurse to administer TPA. So this is what even US is doing at present. Everybody knows that, it's always a tough thing to go to periphery.
Yes, sir. After the COVID, now most of the districts have started having CT scan. But this carotid Doppler and TCD facilities are available only in few centers. I request Professor Desai, sir, to talk about it, how to improve the imaging modality and the availability of carotid Doppler and TCD in districts. In India, around 700 plus districts are available.
Sir, you need to unmute. Kindly unmute, sir.
Yeah. Yeah, because the host was not allowing me to unmute. Now I'm okay. It's done. So what is the question? How to improve the imaging modality?
Yes, sir. Because now after CT scan, after COVID, I think the CT has spread everywhere, sir.
Yeah.
So in that way, how to improve the means TCT availability, carotid Doppler? Because even most of the radiologists, they're not confident about the TCD.
Actually, it all depends on the training and the expertise. And honestly, the society should take a big role in trying to teach, conduct more and more CMEs, do the workshops, and especially for carotid Doppler, the hands-on workshop, the CTMR doing the prolonged courses, and which as through the ISNR and the ISVIR, we run the fellowships. So this is just a continuous process of spreading the knowledge and making more and more people aware and more people confident. But more important is teaching and allowing everybody to know exactly what happens. As you're well aware, after COVID, we have seen a lot of peripheral vascular disease, both the venous and the arterial occlusive disease. Similarly, there are a lot of neuro complications, which we have seen in the COVID. Talking about that, sharing your experiences, showing your cases to the large audience and through the Zoom meetings, which has come as a real boon during the COVID, which I think we all have to thank COVID for making this Zoom a real big thing. So that is possible by doing this, and that should be done in a very systematic way, right from the national, the central, the district level, the state level. Everybody should get involved and try and do this.
So to improve the thrombolysis, now most of the neurologists, they are training physicians to do thrombolysis, how to read a CT, because the availability of report 24/7 is difficult. So like that, a few of the physicians, they are trained in echo by cardiologist. Can we train physicians in doing Doppler or TCD, whether it is possible, or because the availability of radiologists 24/7 is very difficult, sir?
It should be there. First, you are asking me a tough battle question, whether we should do that or not. And if if I say yes, the entire IRI will go after me. Okay. See, it has got many different aspects. Training, yes, because ultrasound is today's stethoscope. Stethoscope is being replaced by the ultrasound. So today, most of the doctors, right from the MBBS level, will and are getting pretty used to and getting trained in the ultrasound. So Doppler is a stage further of the ultrasound. So that process is going to happen naturally, whether you like it or you don't like it. And yes, it is very possible. But the corollary to the statement that the radiologists are not available is not very true. I think we should aim to train the radiologists in a big way and make them confident in doing all these things. Because availability is not only the answer. The expertise is an issue. Many people are not very comfortable in doing the Doppler, especially the carotid Doppler, and that may be the reason why they shy away from trying to do that. So teaching radiologists should be our prime aim, to be honest, rather than teaching other branches. Not that I'm against that, but yes, as an integral part of a radiology society, I firmly believe somebody who has been well trained all throughout his postgraduate course, doing this day in and day out, is a more appropriate candidate to be taught and to be made more expert.
Yes, sir. Thank you, sir. Sir, to Vijay Sharma, sir, mechanical thrombectomy is one of the strongest evidence in medicine. As you said, the number needed to treat is 2.5. Even the PCI for MI, the number needed to treat is 20.
True.
And defibrillation for ventricular fibrillation, the number needed to treat is 3. And good news is now we are doing more and more thrombectomy. The window for mechanical thrombectomy has been extended to 24 hours. Means in Karnataka from Bidar, which is far away, the patients can reach Bangalore, the nearest center, or wherever the thrombectomy facility is there. But in India, hardly we are doing 3,000 to 4,000 mechanical thrombectomy per year, whereas the potential is 2.5 lakhs to 3 lakhs mechanical thrombectomy. So how to improve this gap, sir?
So the gap, when you mentioned the number, in Singapore, which is just 53 lakhs. There's a 53 lakh population. I think it should be less than Bangalore, right?
Yes, sir.
So we are
more than
we are doing about 400 thrombectomies a year. Right, so your number should be in lakhs. I totally agree with. It all boils down to education. That unless the treating physician in periphery knows that this treatment is available, the things will not change. So it has to be education at every single level, starting from neurologists to physicians to to the nurses, to the community, that there is a treatment available, because now people are aware that if somebody tells them, because a lot of people from India, from UAE, Bangladesh, Sri Lanka, they run to Singapore. When they can reach from India to Singapore, reaching from just 50 kilometers away from you, it should not be a problem. Probably it's a lack of awareness that if I go there, I improve my chances of survival and survival with independence. If that thing goes out, this definitely, my way of teaching is, don't teach them the functional independence, because nobody understands what is functional independence. Teach them death. Everybody is scared of death. How cardiologists progress, they tell everybody that once you get MI, your chances of dying are very high. Nobody talks about anything else because there is no functional recovery. Nobody talks about ejection fraction. If cardiologists start talking that I do stenting for you and your ejection fraction from 45 will go to 55, nobody will go for it for stenting. You teach them, if you get MI, you are going to die. I'm going to treat you because I'm going to save you. So we tell our patients, I'm going to improve your functional ability. A 67 or 75-year-old man said, I have lived enough. I don't need anything more. If my one hand is not moving, doesn't matter at all. So we need to teach them that we are reducing your mortality. Probably that will be a scary thought for them. But definitely, this is jokes aside, but we need to teach that these facilities are available. I'm sure that people are not aware that facilities are available. Cost definitely is a major issue everywhere in the world. That people know that if they reach a center which is having these capabilities, cost may become an issue. But once you compare, the cost of a treatment versus your living standard to survive, it is cost-effective treatment. So just I'll say just more extensive and more aggressive educational programs are needed. It's a problem everywhere in the world. You need to educate people.
Thank you, sir.
Can I add something to that? Am I allowed?
Yes, sir.
Yeah, that's an excellent comment. But I'll tell you, there are two main reasons why thrombectomy is not happening in a big way. Because statistical data is one, and we say it should happen. One, the absence or non-availability of a level of expertise to do the thrombectomy, because it's a very skilled procedure. And second, which is far more important, and which I blame the neurologists. Most of the neurologists are highly conservative, and they do not think of the thrombectomy at all. They don't know the indications. They sit tight on the infarcts. They only do the TPA, and then they pray to God. They don't think of the option of a thrombectomy in most of the cases, even in the deserving cases. And that's a real truth. And we keep on seeing these cases most of the times. They're on day-to-day basis. And therefore, that you want to take it up with your own neurologist. Then comes the draining people. Because please accept one thing. Whatever you do, the stroke patient is going to go to the neurologist. He's never going to come to the radiologist. So he will land with the neurologist. And if the neurologist is not available, not trained, not enlightened, this will continue.
Correct, sir. So now slowly, I think neurologists are getting educated about the mechanical thrombectomies. And one more thing for secondary prevention. So when we evaluate a stroke patient, most of the physicians and including the neurologists, they will do CT brain and only carotid Doppler. So in India, as Professor Vijay Sharma sir said, So intracranial atherosclerosis is also major factor. About 1/3 of patients may be having intracranial atherosclerotic disease. So when we evaluate a stroke patient, it is important to evaluate the whole vascular tree. So if you are doing carotid Doppler, you should do a TCD, or you should do MR angio neck and intracranial vessels, or CT angio neck and intracranial vessels, because some of the radiology centers, they do intracranial vessels only and they miss extracranial because that charge is extra. So even majority of centers where I go and talk, I'll tell them you include please neck angio also, otherwise it is an incomplete evaluation. And coming to the intervention for intracranial atherosclerotic disease. So the various trials have shown that if a patient comes to you with the first episode of stroke, and if patient has got intracranial disease, best medical treatment is the best option for those patients. Both bypass trial and intracranial stenting trial, both have failed. So even bypass was attempted, 2 trials came and both trials was negative. So if a patient on medical management, if a patient develops second episode of TIA or stroke, depending on the center, in India, most of the centers, intracranial stenting is very easy because the bypass surgery, majority of neurosurgeons, they don't do. I think this is the one information I wanted to clear. It depends on the country, it depends on the center. In our center, intracranial stenting is safer. We don't do bypass surgery. We do bypass surgery mainly for Moyamoya disease, where we can't do intracranial stenting. I think that is one message I want to treat. So if a patient has got intracranial atherosclerotic disease, we need to give maximum medical treatment. Okay, if it fails, angioplasty and stenting is an option.
I totally agree. I totally agree. That's the current approach. That's the current approach. Yeah.
Okay, sir. I think, sir, there
Yes,
are no.
sir, the one point, the window period, how much is the allowed window period? Because that is the main concern where we cannot get the patient. That is
Sir,
there.
IV thrombolysis, the window is, according to the guidelines, the window is 4.5 hours time. Mechanical thrombectomy, the window has been extended up to 24 hours time, not only for anterior circulation, even posterior circulation also.
Yeah, because patients to get a scan, then get a thrombolysis, then attempt for thrombectomy. So people are worried because ultimately the results, they want everything results
So
oriented.
if we have to develop stroke centers in district places, we need to identify 1 or 2 hospitals where there should be a stroke protocol, where the center should have a CT scan. The only investigation which is required is GRBS, and it should be done door to needle time should be done within 60 minutes time. And some centers we do in 15 minutes. So unless if for example, if a neurologist is in a clinic and if he sees a stroke patient, then refer to a scan center, that is not going to work, sir.
So that's not only CT is sufficient, or you require 1 or 2 sections for diffusion.
No. CT is sufficient if you are doing IV thrombolysis within 4.5 hours window. If NIHS is more than 6 or 10, then that patients can be referred to higher centers for mechanical thrombectomy, because earlier means the window has been extended up to 24 hours time. Means even from Delhi they can come to Bangalore, sir.
Absolutely.
The other thing is the cost. Is there any chances of these drugs coming down, cost effectiveness?
Sir, I think tenecteplase, the cost has reduced. Recently, we had a patient from Ballari where they started IV and shifted to Bangalore after 12 hours. Means the patient took 12 hours from the onset, but we did mechanical thrombectomy. I think in Mysore, they're coming with Indian stent retrievers. And few in that way, the cost will also come down, sir. But the cost of disability, I think even if it is lakhs, it should be given, because afterwards, if the patient is disabled, he will lose his job. One member of the family has to be there with him throughout the means till the patient improves. So the disability and the death, the cost we can't compare with that, sir. Even many cost analysis studies have been done in Europe, US, and so it has been shown that mechanical thrombectomy has got significant cost benefit.
Like in cardiac primary PTCA, like in in stroke, can we attend for a primary thrombectomy directly?
There are trials which has compared direct mechanical thrombectomy with bridging. I think the most of the trials, the results are same, sir. There is no significant difference.
No, because cost getting an MRI, CT, then MRI, then thrombolysis, then thrombectomy. So
Yeah.
like
So now the
anything.
future is direct to cath lab studies, trials have started. Where now means since many years, even in our center, we have a cath lab which has a CT facility. So means in future, the patient with a stroke, if it is an advanced center, not for all patients, if it is a facility is not available, you should give IV. If it is an advanced center, if it patient comes, if it is a proximal large vessel, for example, ICA, terminal T occlusion, in those patients, we can take directly the patient to cath lab, do a CT and do thrombectomy. I think the results and of those trials are awaited, sir.
So there is one question in chat box: problems due to thrombolysis after window period, failed thrombolysis.
Bleeding. That's the only complication if you do it after 270 minutes. Not only there is no benefit, there is a minimal chance of a benefit, but you are definitely increasing the risks of causing symptomatic internal hemorrhage. Probably no go unless you are dealing with in a center with advanced imaging, and you show it that there might still be a benefit, and you don't have any large vessel occlusion to take the patient for thrombectomy. We do it, but this is all off-label beyond 4.5 hours. Never attempt to give TPA to a patient beyond 4.5 hours. It's not defensible thing, and it's not going to work at all. Occasional patient may improve, but you are landing up in problem most of the time. It's totally off-label. Dose of tenecteplase, what I understand in India is 0.2 milligram per kilogram body weight as one bolus. Vikram?
Yes, sir.
Yeah, because clinical trials are still testing 0.25 versus 0.4 milligram per kilogram body weight. They're trying to find out in West which dose works best. But India, the approved dose is 0.2 milligram per kilogram body weight. Time taken for CTA, few minutes, not more than that. It's the processing actually which takes a little bit of time, maybe 5 minutes, maybe 10 minutes. But it's a very fast technique. It does not consume any time, and it does not waste any time. The technique is, if a person comes to my hospital, he gets a CT scan, and if the CT scan does not show a bleed, on the CT table, he gets a TPA bolus. And then only we proceed for CT angiogram. We don't do CT angiogram first and wait for the CT angiogram findings. We just look at the CT scan and just administer TPA, and then we start doing. They're very fast methods. For stroke, when it came to the question of cost about doing MRI, CT, CTA, MRA, when you compare the cost of these tests versus the kind of life which you are providing to the patient, it is still a very cost-effective treatment. There's no comparison. That's cost is nothing actually. At our center, the cost is always a problem. MRI is charged separately, MRA is charged separately. What we have done is that we have created, it's called as MRI stroke screen. So we have removed certain sequences. We just keep a bare minimum. There is we keep one flare on axial. We keep diffusion. We keep the ADC, and then we do a time of flight MRI. We don't do every sequence, and what we found was we have cut down the cost. That the combined cost is just $100 more than a plain MRI. So it's not a costly thing. So you can, if you are sure that you are going to do the CT scan for stroke, you don't need all sequences. There's no point of wasting time, because these are time-consuming tests. MRI, CTA, not essential. No, it's not essential at all. You need to get a CT scan only to administer TPA. But as the NIH starts going up, so it is like this: if your NIH stroke scale is more than 10, there is a 85 to 90% probability that you are having an intracranial large artery occlusion. This is where we do the CT angiogram. That we do it when we know that we are going to proceed with endovascular treatment following TPA administration. So it's not like that we complete TPA. We just start TPA, take the patient to angio suite if we have a large artery occlusion. So it's not essential to do MRA, CTA for only TPA. For larger stroke, for strokes which are severe, yeah, you need to have vascular imaging, whether you do it at your center or you transfer the patient to a center with mechanical thrombectomy and they will do it there. Both things work. It's totally your choice. It totally depends on what is more feasible in your setup.
Sir, Srinivas, there is one question. MRI is better or CT is better?
I mean, it's decidedly MR is better, but I mean that question is all long ago. At our center, all the stroke, what we have something called is as the code gold. Code gold is when patient comes with a stroke, the code gold is announced, and the patient is seen by a radiology resident, an interventional radiology resident, a neurology resident, and a neurosurgeon at the same time. And patient goes directly to the MR, and we have the MR protocol of the stroke protocol, as very rightly mentioned. We don't need too many sequences. We just do 4 sequences and decide about the thrombolysis. TPA is already started most of the times, and then decide about the mechanical thrombectomy. So MR decidedly is 100% better than CT, but across the globe, even today, most of the people are still doing CT as a preliminary investigation to exclude bleed and then start. Because the MR is not been officially recommended as in the protocol of the thrombolysis. So both are equally good, but we do MR. We stand, and in terms of the diagnosis, decidedly MR is far better because diffusion is going to show you infarct, which CT might not see and completely miss.
Correct, sir. And but if you don't have the facility of MR, CT is enough for thrombolysis.
Oh yeah, no question of that. CT is enough. You want to do the CT perfusion, even CT perfusion can give you the added information if you're really looking for it.
To Lokesh sir, so are we medico-legally responsible if we don't thrombolyze the patient? Like if we don't give the offer the thrombolytic agents or mechanical thrombectomy?
Yeah, there is no doubt in that. There is no doubt in that. People are quite educated nowadays, and now, I mean, like it's high time that this particular aspect, what you mentioned, has to be told that to the physicians, and especially in the nursing homes and all those people, that within 3.5 hours, 4.5 hours, within the window period, the patient has to be referred to the stroke ready hospital. There's no doubt in that.
It's very, very clear that if you give TPA to a patient and patient bleeds and dies, and the family goes to court, you are always going to win the case. If the patient came in the treatment window, you don't give TPA, patient improves completely on its own, he goes to the court, you always lose.
Okay.
That is a criminal negligence for not giving TPA to a patient who was eligible for TPA. It's a criminal negligence. All US is the most litigious society. All cases which go in patient's favor are the one where TPA was not given. Even when the TPA was given off-label and physician justifies that although the indications were not very strong, but in patient's interest, I still gave TPA to give him a chance for survival. He still will not lose the case because he was willing to act. Not acting is not acceptable anywhere.
Okay, sir. Thank you very much, sir. So it is already 8 o'clock. So to conclude, stroke is a treatable and preventable disease. If CT brain plane is enough to thrombolyze the patient, the one more investigation which is required is GRBS. IV thrombolysis window is up to 4.5 hours time. In India, we can use either Actylyze and Tenecteplase. Even Tenecteplase has been recently approved up to 4.5 hours time window. For large vessel occlusion, mechanical thrombectomy, we need to offer those patients. Earlier, the window was 6 hours. Now it can be extended to 24 hours. Thank you, sir.
Thanks.
Yeah. So before we conclude, we want a key takeaways. One message for the audience from Dr. Vijay Sharma and all faculty. So your message to the audience, sir.
Every patient should receive TPA plus minus thrombectomy. If possible, do thrombectomy. Every single patient, give them a chance, and always change your lifestyle. Don't let the stroke attack you. That's the best way.
Yeah. Dr. Lokesh, your message?
To all the physicians who attended here, and my suggestion is public awareness. whenever you come across a patient with a diabetic and hypertensive, keep a small brochure, print it with your letterhead and all those things, and with symptoms of stroke and the treatment available, and then please hand over that along with the prescription for diabetes and hypertension. That will go a long way, sir. I'll tell you, it's a very simple thing. It will promote the facility wherever the XYZ is working, and you can just give a very simple instruction about diabetes or hypertension management along with stroke signs and symptoms and the treatment available. I think that's one thing that anyone, any physician at MBBS level can do that.
Thank you, sir. Dr. Desai, sir.
Time is brain. Most important, time is brain. And therefore, what is normally said when you have a stroke and when a general physician or the family physician sees the patient, and if he refers the patient to a private center, you do the CT, you do the MR, and you diagnose, and then you decide that he needs a further treatment, and then he goes to the stroke center or a hospital, and a lot of time is wasted, and it could be more than 4.5 hours, it could be 6 hours. So I honestly, I will request that if you have a stroke patient, try to refer that stroke patient directly to the stroke facility hospital, so that time is not lost, the diagnosis is done properly, and the treatment is started immediately. You can save huge number of patients, if not of mortality, of morbidity for sure.
Thank you. Thank you. So Vikram, doctor, your message to the audience.
Stroke is a preventable disease. So secondary prevention, when we are evaluating a patient, please do evaluate the whole vascular tree along with the cardiac workup, because majority of restrokes happen because we don't evaluate completely.
So thank you, sir. To conclude, I thank all the faculties, especially Dr. Vijay Sharma for accepting our invitation, Dr. Vikram, Dr. Srinivas Desai, sir, for Lokesh, for all of you for sparing your valuable time on this day. And lastly, the audience who have joined from all over the country to say, because most of them are from Tamil Nadu, Uttar Pradesh, Delhi, so many other places. Anyhow, it was a good. I thank all the audience for attending. I once again thank Dr. Vijay Sharma, Dr. Vikram, Dr. Srinivas, and Dr. Lokesh for accepting our invitation on behalf of API and other organizations. Thank you one and all. Thank you for sparing your valuable time. Thank you, sir. Good night.
Thank you.
Thank you.